Hi, welcome back to Nextillo's live lecture series. I hope I am audible. If I am, you can just write a yes over there so I know that it's the right time to start. Yeah? Am I audible? Hi, guys. Great, great. All right. So welcome back to Nextillo's live lecture series. I am Dr.Smriti and I am your faculty of pathology. Let me first begin by appreciating this amazing team here at Nextillo, who has given such a great platform for us to help students like you clear your exams, and especially Dr. Sunil, who has conceptualized this platform. Also, I would like to give you a news over here that they have launched a helping hand coupon, which will give you an access to our entire course for 3 whole months at just ₹89. So I'd suggest go download the app and subscribe to their course, and you can make the most of it. Okay, then I think we can begin now. So our topic for today. Just a second. All right. So I hope my screen is visible now. Our topic for today is RBC's disorders. So as we know, blood is the vital fluid, and okay, so we'll start with RBC disorders. I'm going to give you an overview. This is not a very detailed lecture, but we get most of what the questions are asked over here. So let's start with the structure and function of RBCs. So a mature erythrocyte is another word for an RBC. A mature erythrocyte is a biconcave disc, and it is 7 to 8 micron in diameter. So the most essential component of an RBC is hemoglobin. We know that, right? Hemoglobin is responsible for transport of oxygen from our lungs to our cells and tissues, and it takes away carbon dioxide from the cells and helps us throw it out via our lungs again. Okay, so now hemoglobin is composed of two primary parts, the heme and the globin. Heme is composed of iron and protoporphyrin. Okay, so heme per se is composed of two components, iron and a protoporphyrin, while globin are polypeptide chains. So in a human hemoglobin, there are 4 polypeptide chains, or 2 pairs of polypeptides. Right now, an important question that is asked is the composition of these polypeptide chains. So in adults, we primarily have 97% of hemoglobin type A, which has 2 alpha chains and 2 beta chains. All right, so 97% of hemoglobin A. Then we have a little bit of hemoglobin A2. The 4 polypeptide chains over here are 2 of alpha and 2 of delta. Okay, so hemoglobin A2 is alpha 2 and delta. Then hemoglobin F. Hemoglobin F is fetal hemoglobin, but still you can find it in adults in a very minute amount. That's about 0.5%. And the composition is alpha 2 gamma 2. All right. So this is the composition of hemoglobin in adults, while in newborns, primarily we have the fetal hemoglobin, which is about 80%. And what is the composition of fetal hemoglobin? Okay, not audible. Am I audible now? Is it getting better? Hi, am I audible now? I've worked on some settings now. Is it better? Great. So let me repeat the important things that you may have missed. So the size of the RBCs is about 7 to 8 micron. It is a biconcave disc. Hemoglobin consists of two parts, a heme portion and a globin portion. Heme is composed of iron and protoporphyrin, whereas globin has 4 polypeptide chains. Okay, that means 2 pairs of polypeptide. So in adults, 97% is hemoglobin A, which is composed of alpha chains and 2 beta chains. 2.5% is hemoglobin A2, which is composed of 2 alpha chains and 2 delta chains. And also you can find a very small amount of fetal hemoglobin, about 0.5%, which is composed of alpha 2 and gamma. All right. But in newborns, predominantly we find hemoglobin F, which is the fetal hemoglobin, and the composition is alpha 2 and gamma. Okay. Besides hemoglobin, there is a membrane around the RBCs, and there are some important skeletal proteins. For example, spectrin and chirin. Then there is a band protein 4.1. There is actin and many others. Why you need to remember this? Because any defect in any of these proteins may cause membrane defect. Okay, let's just. Is it still breaking? Let me just. Give me. Okay, I'm using a mic now, so I hope it's better now and we can avoid any more disturbances. I'm really sorry about this. Okay, mic testing, is it better? All right, great. So sorry about this. Okay, so let's proceed. I was telling about the membrane. So besides the hemoglobin, which is an integral part of RBCs, we also need to know other structures. Any tweaks in the structure may cause different pathologies which lead to different types of anemia. So that is why you need to know about other structures in the RBC as well, besides hemoglobin. For example, membrane, like there are proteins in the membrane called spectrin and chirin, protein 4.1 and actin. And you need to know a little bit about enzymes as well, like there are some enzymes in the EMP pathway, which are helpful in glycolysis. Then there is a Rappaport-Luberin shunt, which helps in 2,3-DPG synthesis. So all these enzymes, any deficiency in any of these enzymes may again lead to a defect in the RBC function, and hence some kind of anemia. All right. Okay, so what exactly is anemia? Well, the definition of anemia is reduction in concentration of circulating hemoglobin or reduction in the oxygen carrying capacity of blood below the level that is expected for healthy people of the same age and sex in the same environment. Over here, I have added a picture of the RBC to give you, to give you an idea about the shape of RBC. So RBC is basically a biconcave disc. That means it is indented from both sides, and it is round with 7.5 micron diameter. Okay, so here is a chart to give you a little bit idea about what a normal RBC would look like when you see it under the microscope, and then how would abnormal RBCs would look, so that you can differentiate different kind of causes, right? So, so the first picture here shows you a normal RBC, which is about 7.5 micron. When you look at a slide, we generally cannot measure inside the microscope unless you have those kind of microscopes which have those scales attached to them. So in a general smear, how do we approximately see the size of the RBC? We compare it to the size of a lymphocyte. So if the nucleus of the small lymphocyte is almost equal to the size of the RBC, then we call it a normal sized RBC or a normocytic RBC, okay? Then below it, you can see a microcyte, which is obviously smaller in size, micro, smaller, right? Then below that is a macrocyte. Again, we get an idea inside the microscope by just comparing it to surrounding small lymphocytes. And if the cell appears smaller than the small lymphocyte, then it is a microcyte. If it appears larger than the small lymphocyte, it is a macrocyte. All right. Now we come to a very important topic, which is RBC indices. Why are these important? Because depending on the value of these is how we classify the anemias. So first is MCV. Now, what is MCV? It is called mean corpuscular volume. That means average volume of the RBC that we see in that particular sample. You also need to know the normal ranges so that you can determine whether the value for the particular patient is less than the normal range or more than the normal range. And depending on that, you can classify the sample or the blood as microcytic or macrocytic. So the MCV normal range is 81 to 100 femtoliters. If the MCV comes lower to this, it is a microcytic kind of a picture because the volume is less. If the MCV is more than that, then we call it macrocytic picture. That is, the RBCs are larger in volume than normal. Then we come to MCH. MCH is mean corpuscular hemoglobin. Now, what is the normal range? It is 26 to 34 picogram. So this tells us whether in a particular cell, hemoglobin concentration is lesser or higher than normal. Third is MCHC. Now, this is mean corpuscular hemoglobin concentration. So over here, we are not focusing on single cell, while we are focusing on the entire sample as a whole. So on the in the above two, you see that the denominator are RBC counts. That means in particular RBC, what is the volume and what is the hemoglobin? Whereas in MCHC, the denominator is the hematocrit. Hematocrit is the total number of, the packed cell volume. So over here, we see on an average in the entire sample, what is the hemoglobin concentration. And last but not the least is RDW. So RDW is red cell distribution width. Okay, so what is red cell distribution width? Basically, when we plot the sizes of RBCs on a graph, we get the width of the graph that we get is the RDW. So if all the RBC sizes are very similar to each other, then we'll get a smaller width graph. Whereas if we have smaller cells also, medium-sized cells also, larger cells also, we'll get a wider graph. So that is what is called as RDW, or red cell distribution width. Now, the higher the RDW will tell us that there are more shapes and sizes of RBCs in this particular sample. Okay, so the normal range is 11.5 to 14.5%. All right. Now, let's quickly classify anemias depending on etiology. What is etiology? Etiology means the cause. What is causing anemia? Now, if we think, what is anemia? Anemia is basically decrease in the hemoglobin level or decrease in the oxygen carrying capacity, right? So basically anything that is affecting RBCs, and that is how affecting the hemoglobin. So what can cause decreased amount of RBCs or decreased amount of hemoglobin? Well, it can be either decreased production. That means there is some problem in the body because of which the RBCs are getting formed in lesser numbers. Okay, or there can be they're being formed in normal numbers, but there is somehow an increased destruction. They're being formed, okay, but they're somehow being destroyed in the body. So that is anemia due to excessive red cell destruction, which is called hemolytic. Blood lysis means breaking down. So hemolytic anemias, right? And then number 3 can be that they are being produced, okay, and they're not being destroyed inside the body, but there is some sort of blood loss, some bleeding happening from somewhere, because of which we are losing the RBCs, and that is why there is some kind of anemia. So coming to the first one, anemia is due to impaired red cell production. Now, why will there be a decreased red cell production? Decreased production can be because either the nutrients required by the RBC for formation or by the hematopoietic precursor cells is reduced in our body. So we know that there is a heme portion which requires iron. So if there is deficiency of iron in your nutrition, then it will lead to iron deficiency anemia because heme portion will not be formed properly. Right? Then there can be a megaloblastic anemia. Why does it occur? It happens because of deficiency of either folic acid or vitamin B12. Now, folic acid and vitamin B12 are required for DNA synthesis in our body. So if proper DNA synthesis is not happening in the cells, then again, there'll be deficiency of RBCs because decreased formation. Okay. Then number 3 is anemia of chronic diseases. Now, if a patient is suffering from any sort of chronic disease, then in that patient also there can be anemia. Why? We'll come to it in a while. Then we have sideroblastic anemia. Now, what is sideroblastic anemia? That the amount of iron is normal, but it is accumulated in abnormal forms, because of which it is not available for proper hematopoiesis or for proper formation of RBCs. Then number 4 can be aplastic anemia. Now, what is aplastic anemia? It is a bone marrow disorder in which the entire cell lineage, be it RBCs, be it WBCs, be it platelets, all of them are affected because of some disorder in the stem cells. Okay, then there can be other causes like in liver diseases because of some hormonal effects, like in endocrine, and then other very rare causes like myelodysplastic anemia or congenital dyserythropoietic anemia. Then we come to second important cause, which is due to excessive red cell destruction. Now, they are being formed normally, but in the body, they are being destroyed because of some reason, right? Now, as we discussed, the structure of the RBCs. If there is any problem in the structure, our body will recognize that these RBCs being formed are not normal, and they will try to remove these abnormal cells from our body. So in the structures, we had read about hemoglobin, we had read about enzymes, and we had read about the membrane. So any problem in any of these structures, be it the membrane, be it the type of hemoglobin that is being formed, or be it the type of enzymes, any abnormality, the body will detect that the RBCs being formed are abnormal and hence try to remove them by destroying them. Then these were abnormalities which are intrinsic to the red cells. Now, there can be some abnormalities which are not within the red cells, but outside the red cells, which are causing destruction of the RBCs. For example, our immune system, there is some problem in our immune system which is recognizing normal RBCs as some foreign object and destroying it, which is called as an autoimmune condition. So in every autoimmune condition, as we know, our immune system finds our very own cells as foreign and forms antibodies against it. So it can be autoimmune. Now, it can also be alloimmune. What is alloimmune? The antibodies which are destroying the RBCs are not our own. They are from outside. For example, in a mismatched blood transfusion. So if the antibodies of some other person are transfused in us and the transfusion has been mismatched, it will lead to hemolysis, which is called as alloimmune. Now, there are also some drugs which can cause hemolysis, which will be called as drug-induced hemolytic anemia. Now, besides antibodies or immune-mediated hemolytic anemia, there can be mechanical destruction. So what can be the causes of mechanical destruction? It can be microangiopathic. Now, let's break down this word. What is microangiopathic? Micro means small, angio means blood vessels, pathic means any pathology. So anything that goes wrong in the small blood vessels. For example, there are clots in the small capillaries, because of which the RBC flow is being obstructed. Now, due to this increased friction because of the clots in the capillaries, the RBCs will be destroyed. They can also be cardiac, like any kind of valves which have vegetations or mechanical artificial valves which have been transplanted in a patient. So these artificial valves, when the blood flows through these heart valves, they'll also lead to some kind of trauma to the RBCs, causing destruction. Number 3 is March hemoglobinuria. Now, what is March hemoglobinuria? It is generally seen in marathon runners or soldiers who have been marching for very long distances. So because of the trauma to their feet and the blood vessels in their feet due to repeated marching or walking, the RBCs get traumatized and get broken down. Then there can be direct actions of any physical, chemicals, or infectious agents. And last is hypersplenism. So we all know that all our blood cells go and die in the spleen. So in any cases where the spleen is overactive, there'll be excessive destruction of red cells. Now we come to the features of anemia. So the features of anemia will be pallor, that is pale looking skin, paler conjunctiva because of the low hemoglobin, then tiredness because hemoglobin levels are very important for our oxygen and carbon dioxide exchange. And if that is not proper, then obviously we'll feel more tired. Similarly, weakness. Now, dyspnea, there'll be difficulty in breathing on exertion. Palpitations, because the heart will try to compensate for the decreased hemoglobin by pumping more blood, which will increase your heart rate, and there'll be palpitations. And due to long-term very high anemia, the heart can get overworked which may lead to heart failure. Okay. So let's start with the broad topics now. First is anemia due to a decreased production. So as we discussed, decreased production can be due to a lot of causes, decreased nutrients or any chronic disease or any kind of bone marrow failure. Now over here, we start with megaloblastic anemia. Now, what is megaloblastic anemia? As the name suggests, mega means big, blastic means the blast cells or the immature RBCs in our bone marrow are larger than what are normally seen in the patients or in normal subjects. So how do we recognize a megaloblastic anemia? As we already discussed, the volume or the mean corpuscular volume over here would be more than 100 femtoliter. Okay, now why does it happen? It happens because there is impaired DNA synthesis. So as we know that vitamin B12 and folic acid are important for DNA synthesis in our bodies. They are required for synthesis of thymidine. So we know that our DNA has those 4 base pairs, A, T, C, G. So the T, that is the thymidine, vitamin B12 and folic acid are required for the synthesis of those. Now, deficiency or impaired metabolism results in defective nuclear maturation because of the deranged DNA synthesis. Now, the DNA is not being formed properly, because of which the nuclear maturation will be delayed. Now, the RBCs are not being formed properly, so the body will try to compensate by releasing more hormones, which will try to synthesize more RBCs. So for that, we have a hyperplastic or hypercellular bone marrow that we'll find in megaloblastic anemia. Also, now because DNA is found in almost all the cells, not almost, in all the cells of all the nucleated cells of our body. So a deficiency of vitamin B12 and folate does not just affect the RBCs, it affects other cells as well. So the neutrophils or the WBCs will also be affected. Now over here, a very important feature that also helps us recognize a megaloblastic anemia are hypersegmented neutrophils. What are hypersegmented neutrophils? So generally a neutrophil will have 2 to 5 lobes. But if any neutrophil has more than 5 lobes, it is called a hypersegmented neutrophil. So to diagnose a megaloblastic anemia, if more than 5% of your neutrophils have more than 5 lobes, or even if you see a single neutrophil with more than 6 lobes, then you call it a hypersegmented neutrophil picture, and it helps you diagnose a megaloblastic anemia. Now, as vitamin B12 is also very important for our nervous system, this megaloblastic kind of anemia may also be associated with neurological symptoms like subacute combined degeneration of the spinal cord. So there'll be spinal symptoms. Okay, there'll be some sensory issues. Along with a megaloblastic blood picture, there will be some neurological symptoms in the patient. Now, what can be the causes? Very obviously, it can be a decreased intake or inadequate diet, especially in vegetarians, because a vitamin B12 and folic acid is found in very few of the vegetarian diets. Then there can be impaired absorption. You're taking absolutely normal amount, but it is not being absorbed properly in your gut because of some kind of malabsorption syndrome, or a very important enzyme in our body which helps in the absorption of vitamin B12 is intrinsic factor. So if there is intrinsic factor deficiency, which intrinsic factor is being secreted in our stomachs. So if there is intrinsic factor deficiency because of any cause, again, vitamin B12 will not be absorbed, hence leading to a megaloblastic picture. Now, again, pernicious anemia and gastrectomy are related to intrinsic factor deficiency. Pernicious anemia is an autoimmune condition in which the lining cells of the stomach are destroyed by autoantibodies, and hence intrinsic factor will not be released. And again, gastrectomy, very similar. When the stomach is removed, there's no intrinsic factor, and hence vitamin B12 is not being absorbed. So those were the causes of megaloblastic anemia and how we identify a megaloblastic anemia. So if we see just an MCV of more than 100 femtoliter, we do not directly label it as megaloblastic. We call it as macrocytic anemia, because megaloblastic characteristically means that there is deficiency of vitamin B12 or folate, whereas there can be other reasons for MCV to be more than 100. Those other reasons can be some kind of liver disease, or in spherocytosis, we find MCV more than 100. So just MCV more than 100 is not characteristic of megaloblastic. So we have to do other tests to find out the exact cause of why we are seeing a macrocytic blood picture. Generally, a bone marrow examination is done. So as I've already told, you find a very hypercellular bone marrow picture, and there'll be large sized blasts, erythroid precursors in the blood. And because there is delayed maturation of the nucleus, we find a very sieve-like pattern in the nucleus of these blasts. Okay, and I have a picture over here, a peripheral blood picture. So these cells marked by the arrow are the macrocytes. We can see that these are larger in size than surrounding cells. These are the macrocytes, and not necessarily megaloblasts unless we do, not necessarily a megaloblastic picture unless we do further tests. Okay, so that was because of iron deficiency anemia. Now we come to that was because of vitamin B12. Now we come to iron deficiency anemia. Okay, so iron deficiency is most common nutritional disorder in the world. Okay, it can be again due to either decreased ingestion of iron or increased loss of iron. Now, an iron deficiency anemia will have a microcytic, that is low MCV, and hypochromic, that is low MCHC picture. If an adult man comes to your OPD and you find microcytic hypochromic blood picture, or a low hemoglobin with low MCV, low MCHC, the first and most important cause that you need to rule out in that patient is a GI blood loss, because mostly in men, the dietary intake of iron is normal as needed by them, whereas in women it is the dietary requirement is higher due to menstrual blood loss. So if an adult man comes to you, you have to rule out some kind of blood loss from the body, some kind of hidden blood loss, and first we go to the GIT. While in premenopausal women, the most important cause is menstrual blood loss due to menorrhagia. In postmenopausal women, again, we'll rule out GI blood loss. The most important tests that we do in iron deficiency anemia are serum ferritin and bone marrow iron stores. What is serum ferritin? We'll just come to it in a while. Now, anisopoikilocytosis is seen in iron deficiency anemia. I know it's a huge word. It sounds like some gibberish, but let's break it down. So anisopoikilocytosis means, aniso means that there is a variety of shapes and sizes of cells. So in an iron deficiency anemia, you'll find a normocyte, you'll find a microcyte. So these are different sizes, and there'll be different shapes as well. So if you can appreciate in the picture, there can be cells which look like raindrops or teardrops. Then there can be some elongated kind of cells which look like pencil-shaped cells. And there can also be cells which have a target-shaped appearance. So we play that game in which we throw the darts on the targets. So this is what the cell looks like. They have a central darker area which give them a target board-like appearance. So these are called as target cells. So in iron deficiency anemia, you see a variety of shapes and sizes in cells, and hence there'll be a higher RDW. RDW, as we discussed, a red cell distribution width. When we plot the sizes on a graph, we'll find a wider graph. So hence, in an iron deficiency anemia, the RDW is mostly higher than normal. Now, what is a Menzer index? Again, a very important question that is asked on this. Menzer index is basically to differentiate an iron deficiency anemia from thalassemia. Now, thalassemia also has a very similar picture. There'll be, microcytic hypochromic kind of cells. You can see target cells over there, but the RDW is not so high. So, the Menzer index is a formula to differentiate it from thalassemia. That is when you divide the MCV of that particular sample from the RBC count. If the ratio comes less than 13, it is generally thalassemia. If the ratio comes more than 13, it is iron deficiency anemia. So important to remember Menzer index. Now, let's just quickly talk about iron metabolism and iron absorption, because if you remember this, then you can solve most of the iron deficiency diagnosis questions. Okay. So, this in the center in orange is basically a duodenal enterocyte, or a cell, lining cell of the duodenum. Okay. This is the lumen of the intestine. So when iron is coming in the intestine through diet, it is generally, if it's a heme iron that is taken from meat sources, it is in ferrous form. Whereas if it is coming from vegetarian sources, it is mostly in ferric form. So for it to absorb, it has to first convert into ferrous form, which is done by an enzyme on the surface of the enterocyte called as ferric reductase. Now this ferrous form, or the heme iron, will go inside the cell, or the lining cell, via a channel called the DMT1, dimetyl transporter 1. Now this ferrous form of iron, when it comes inside, it can either be transformed to ferritin. Now what is ferritin? Ferritin is the storage form of iron. So if the cell decides that I just have to store this iron inside me, it'll convert this ferrous form into ferritin. Now, if this iron is needed to come out into the bloodstream in the plasma, it will come via another transporter called as ferroportin 1. Okay, so this ferrous form can come out of the cell into the blood now via ferroportin 1. Now, why is this ferroportin 1 important? Because this ferroportin 1 is regulated by another enzyme called as hepcidin. Now, this is important. Hepcidin is a protein which is secreted and produced by the liver. Now, hepcidin causes blockage of ferroportin 1. So basically, hepcidin helps in regulating how much iron we need to come out of the intestinal cell in the blood. How much iron does body need in the blood to form, to do various functions, right? Be it formation of RBCs or acting as a cofactor in various reactions, right? So hepcidin decides whether or how much amount of iron will it allow to come inside the blood by blocking or unblocking ferroportin. So this hepcidin is, as I told, is secreted by the liver. Now, hepcidin is also an acute phase reactant. So as we know, acute phase reactants are secreted in excess in any sort of inflammatory states in our body. In any kind of chronic inflammation or prolonged diseases, there will be increased hepcidin. And because of this increased hepcidin, ferroportin 1 will be blocked, and hence iron coming to the plasma from the duodenal enterocyte will be less. Okay, so now this iron which comes into the plasma can, attaches itself to transferrin. Transferrin is the transport form, and then it is transported to wherever it is needed, be it the erythroblasts in the bone marrow to form various RBCs, or to the macrophages, or to the liver. Okay. Now let's come to differential diagnosis of iron deficiency anemia. So whenever you see a low MCV, you should not just go to iron deficiency anemia, or whenever you see a microcytic hypochromic kind of a picture, directly do not jump that it is an iron deficiency anemia. You need to see other things which can be a differential diagnosis. So quickly, let's summarize over here. In an iron deficiency anemia, we know that the MCV is decreased and RDW is increased. In anemia of chronic disease, again, it can be decreased and RDW can again be increased or normal. Whereas in thalassemia, the MCV is markedly decreased and RDW is mostly normal. It can be increased in some cases. Red cell morphology over here is microcytic hypochromic kind of cells. You'll see pencil cells. There'll be a lot of anisocytosis. In anemia of chronic disease, on the other hand, we most commonly find a normocytic normochromic kind of a picture. Sometimes there can be a microhypo picture. Whereas in thalassemia, there'll be basophilic stippling, there'll be target cells, there'll be a lot of polychromasia along with the microhypo picture. Okay. How do we differentiate is that serum iron will be decreased in both iron deficiency and in chronic disease, whereas it will be normal in thalassemia. There is no dearth of iron in these patients. In fact, mostly we find it increased. Transferrin saturation again will be decreased in iron deficiency anemia, whereas it is normal or increased because there is normal amount of iron in these patients. Then serum ferritin, which is the storage form, will be decreased in iron deficiency anemia, obviously. It can be increased to normal because in chronic disease, the cell is absorbing the normal amount of iron, but it's just not releasing it to the bloodstream. So it can be increased or normal in anemia of chronic disease. And in beta thalassemia, serum ferritin is absolutely normal. Right. In hemoglobin electrophoresis, you find normal hemoglobin in iron deficiency and anemia of chronic disease, whereas in beta thalassemia, there'll be increased HbA2. Why? Because the normal the hemoglobin A, which is found in predominant amounts, is abnormal. So the other kind of hemoglobin will try to compensate for it. And marrow hemosiderin or marrow iron stores will be low or absent very obviously in iron deficiency anemia. In anemia of chronic disease, again, it can be normal or increased. And in beta thalassemia, they are absolutely normal. Okay, so we come to sideroblastic anemia. Now, what is sideroblastic? There is abnormal utilization of iron during erythropoiesis. Now, the iron there is normal, but it is not being utilized properly. So there are aggregates of iron seen in these premature RBCs or the erythroblasts. Okay, so type 1 sideroblasts are normal. That is, they are seen in normal subjects as well. They have a few cytoplasmic iron containing granules, whereas type 2 and 3 sideroblasts are abnormal. Then what are these sideroblasts? Basically, sideroblasts, these aggregates in the sideroblasts are basically iron-laden mitochondria seen in the perinuclear area in erythroblasts. So another question that is asked generally is that what kind of cellular organelle is affected in sideroblastic anemia? The iron goes and deposits in the mitochondria. Okay, and how do we diagnose it? So when we find more than 15% of marrow erythroblasts as ringed sideroblasts, that means these mitochondria with aggregates of iron are forming a ring around the nucleus, then this is called as a sideroblastic anemia. Now, it causes ineffective erythropoiesis because there is adequate amount of iron, but then it is aggregated in all the wrong places. So it will again lead to microcytic hypochromic type of RBCs, and other causes can be a myelodysplastic syndrome or alcoholism or lead poisoning and anti-TB drugs. Okay, then we have aplastic anemia. Aplastic is generally due to bone marrow suppression. So when a bone marrow is suppressed, it will almost always involve platelets and WBCs as well. Then it can be acquired, anything that is causing the bone marrow suppression from outside, which can be due to drugs, due to radiation, or due to infections like Epstein-Barr virus or cytomegalovirus. It can also be inherited in the form of Fanconi's anemia. Very commonly asked question is Fanconi's anemia. So they'll give you some features, that is like short stature, and there's some skeletal abnormalities, or the patient has some kind of leukemia, and then it'll ask that what kind kind of aplastic anemia can it be? So the answer is Fanconi's anemia. And there can be other drugs like chloramphenicol or some kind of antibiotics or chemotherapy, insecticides, viruses, which can again lead to bone marrow suppression, leading to aplastic anemia. Now, these were decreased RBC production. If any questions till now, you can put it on the chat. Any query regarding decreased RBC production, because now we are moving on to increased RBC destruction. Okay. So increased RBC destruction it is called as a hemolytic anemia. So hemo is blood, lytic is breaking down, and anemia, hemolytic anemia. Right. Okay, so now any kind of abnormal destruction of RBC can either be hereditary, that is, acquired genetically, or acquired after, which is not genetic, okay, acquired, or environmental. So hereditary can be any sort of membrane disorder. So the RBCs are being formed with some kind of abnormalities in the membranes. Example is spherocytosis, or any kind of abnormality in the enzymes. Example is a G6PD deficiency, or any kind of hemoglobin disorders, which are called as hemoglobinopathies. Or they can be acquired, that is membrane defects which are not genetic but are acquired, or they can be antibody mediated, like in transfusions or any autoimmune condition. Then they can be mechanical trauma, infections, drug, toxins, hyperspinism. We've discussed these, right? So let us discuss hereditary spherocytosis in a little detail. So hereditary spherocytosis is an inherited defect in RBC membrane cytoskeleton. Okay. RBC membrane cytoskeleton. Now, as I told you earlier, the RBC membrane is a bilayer, and there are some proteins in these in the RBC membrane which are anchoring the RBC membrane to maintain its integrity. Okay, so what are these important proteins? They are ankyrin, spectrin, band 3 of protein 4.1. Now, any defect in any of these proteins will cause an unstable RBC membrane. Okay, so because of which, what will happen? Number one is that we know that the normal shape of the RBC is a biconcave disc, that is indented from both sides, concave from both sides, right? Now, any problem in the membrane will kind of hamper the it will hamper the membrane elasticity, and it will make it more rigid. Now, this will start becoming more round and more spherical instead of biconcave. So it goes to a spherocyte. Now, this kind of RBC is absolutely round. It is not a disc-shaped cell. It is instead a ball-shaped cell. Okay. Now, because of the increased increased rigidity and decreased elasticity of these cells, they are more osmotically fragile. That means if you put these cells in a hypotonic solution, they will break in this hyperosmotic solutions. Okay. Now, this hereditary spherocytosis is inherited in an autosomal dominant way, And the clinical features are anemia, obviously, hemolysis again. Now, because of hemolysis and increased RBC breakdown, it will lead to jaundice. And we know that all these cells go and sequester in the spleen. So it will cause splenomegaly. And because of the increased bile pigment that will be formed, because of the increased breakdown, it can lead to gallstones. In hereditary spherocytosis, the MCHC will be high because of the dehydration of the cells. The decreased size and the dehydration will lead to increased MCHC, and there'll be reticulocytosis. Now, what is reticulocytosis? Reticulocytes are immature or younger form of RBCs. So when our body detects that the RBC formation is not proper, it'll compensatorily increase the erythropoiesis, and because of which more RBCs will form, and that is why the reticulocyte count will be higher. Now, important topic here is aplastic crisis. Okay, so what is an aplastic crisis? Now, aplastic crisis is a temporary aplasia. Aplasia, as we discussed, was complete cessation of formation of any kind of blood cells, right? Now, so what is an aplastic crisis? In any kind of infection, especially by the virus parvovirus B19, this selectively infects the immature RBCs or the erythroblasts and transiently suppresses erythropoiesis. Now, in a normal subject or in a normal human being, whenever they're infected with a parvovirus B19, it does not cause aplastic crisis because the RBC span is normal. They're absolutely normal RBCs. So even if a few RBCs, even if the suppression is there, it is very short-lived, and the remaining RBCs, mature RBCs, kind of make up for it. But in a person with hereditary spherocytosis or any other kind of hemoglobinopathy where the normal RBCs are very less, so they are not able to compensate for this transient suppression of erythropoiesis that happens. So over here, if there is an infection with the parvovirus B19, it will lead to an aplastic crisis. That is, for a very short amount of time, there'll be sudden stoppage of blood cell formation, and the patient will go into severe anemia, and the treatment is done by blood transfusions over here. Now, second, we come to a G6PD deficiency, a glucose 6-phosphate dehydrogenase deficiency. It is the most common RBC enzymopathy in humans. It is again a genetic condition, but it is inherited in an X-linked recessive manner. Now, what happens in a G6PD deficiency? Again, it's a hemolytic state, but how does hemolysis occur? It occurs on exposure to any kind of oxidative stress. So what happens is that this G6PD enzyme is basically helping the RBC generate NADPH from NADP. Right. Now, this NADPH is reduced, is needed for the formation of reduced glutathione, and this reduced glutathione helps in maintaining the RBC membrane integrity. So if there is NADPH if there is adequate amount of NADPH in the RBC cytoplasm, it'll lead to adequate amount of glutathione present there, and this glutathione is needed for RBC membrane integrity. Okay, so any kind of oxidative stress, what will happen is that this NADPH will go to counter that oxidative stress, and now due to reduced NADPH, there'll be reduced glutathione. Okay, so if G6PD enzyme is not there, there'll again be reduced NADPH. Now, what causes oxidative stress? So it can be triggered by foods like fava beans, generally are not seen very much in India, but mostly in Mediterranean countries. Another oxidative substances like drugs like primaquine and chloroquine. We use this in malaria or other kind of infections which cause oxidative stress to the body. Now, what happens is that oxidative stress causes denaturation and precipitation of the globin chain. As I said, that the membrane integrity glutathione will maintain. Now, if there is not enough glutathione, then membrane integrity is not maintained, and globin chains will get denatured and precipitated. Now, they are precipitated as these blue structures that you see inside the RBCs. This is stained by methylene blue.
these blue structures are called as Heinz bodies, and these are basically precipitated globin chain from the hemoglobin. Okay, now again, this forms abnormal RBCs, and it is detected by our body, and there is acute intravascular hemolysis. So what is intravascular? These RBCs are being destroyed in the blood vessels itself. So now there'll be hemoglobinuria. That means that this broken down hemoglobin, or these RBC breakdown, leads to release of hemoglobin in the bloodstream, and it will be excreted in the urine, leading to hemoglobinuria. And obviously, because of all the hemolysis, there'll be anemia. Okay. Now, RBC with Heinz bodies, when these pass through the spleen, they're again identified as abnormal, and this portion is basically bitten off by the spleen, so it leads to formation of bite cells. Now we come to hemoglobinopathy called sickle cell anemia. Now, what is sickle cell anemia? Basically, we have already discussed the structure of a hemoglobin. So normal hemoglobin is 2 alpha and 2 beta chains. Now in sickle cell anemia, these beta chains, there is a defect in the beta chain that the base pair adenine is converted to thymine, because at the 6th codon of the beta globin chain, because of which the glutamine, which had the adenine, is now converted to valine. So an entire amino acid is changed now. So instead of glutamine in the beta chain, now we have valine. Now, just because of this one small base pair, the entire hemoglobin structure changes, and now this beta chain is defective. So these hemoglobin molecules now undergo polymerization. What is polymerization? All the hemoglobin comes together and forms a polymer instead of separate molecules on their own. Now, what happens because of this polymerization? The RBC shape from a biconcave changes to a sickle shape. What is a sickle? A sickle is that instrument that the gardeners use or the farmers use. So the RBC changes to a sickle shape because the hemoglobin inside it has polymerized. Now, when does hemoglobin polymerize? It basically polymerizes when there is low oxygen tension. So generally in a patient with sickle cell anemia, all the cells are not in the sickle shape. Sickling happens when there is a reduced oxygen tension. Now, this reduced oxygen tension is generally seen in the periphery, due to cold extremities or being away from the lung. Now, this low oxygen tension doesn't immediately cause sickling because there is a lag time. So by the time these RBCs reach back the lung, I mean, by the time the lag time passes, the RBCs reach back the lung to get enough oxygen again. So this sickling normally is not very prominently seen unless there is some kind of problem which is causing reduced oxygenation. So either reduced oxygenation via the lungs, or there is some kind of cold exposure which is causing vasoconstriction, and hence blood is not being able to reach back to the lungs very properly. So, but there is repeated there are repeated episodes of sickling, and when again a normal amount of oxygen comes back, they'll come back to a normal shape. But again, you'll find some amount of sickle cells in the peripheral blood, because due to repeated cycles of sickling and coming back to normal shape, the RBC membrane gets defective, and some then remain in that sickle shape. So you can see those elongated sickle shape kind of cells in the blood. What are the clinical features? Again, there'll be severe anemia, there'll be jaundice, a vaso-occlusive crisis. Now, what is a vaso-occlusive crisis? These sickle cells, again, are very firm and very rigid, and they have very less elasticity. So they can block the blood vessels. Now, because of this blocking, vaso-occlusion occurs, and this vaso-occlusion can occur anywhere in the body, but most significantly is seen in the bone. So it causes bone pain in patients. It can also be seen in spleen and basically cut off the blood supply of the spleen and cause the spleen to just decrease in size and become fibrotic, which is called as autosplenectomy. Okay, again, an aplastic crisis can be seen in these patients because of a parvovirus infection. And the sickle cell patients are kind of susceptible to a few infections, like a pneumococcal infection, Haemophilus influenza infection, and Salmonella osteomyelitis. So a very important question again. Osteomyelitis seen in patients with sickle cell anemia is most commonly seen with the Salmonella strain. Again, it can cause stroke because similar, there is a vasoocclusion that can happen in the brain, and the blood vessel is being cut off by these RBCs and can cause a stroke, and diagnosis is by hemoglobin electrophoresis. Coming to thalassemias. Now, thalassemia is a huge topic. It is absolutely not possible to cover all of it in this live lecture. So I suggest you download our app, and you can learn all about thalassemias in our Nextillo lecture series. Over here, I'm just giving a very small overview. So thalassemias are basically diseases involving the globin chain synthesis. So as we know, there are alpha globin chains and beta globin chains in normal hemoglobin A. Now, these if the defect is in the alpha globin chains, it is an alpha thalassemia. If the defect is in the beta globin chain, it is a beta thalassemia. Also, depending on the severity, it can again be major or minor. And the RBCs are abnormal, so there'll be hemolysis and a microcytic kind of anemia. On the skull X-ray, you get a crew cut kind of appearance. That is, the bone gets like this because of the excessive formation or the hyperplastic marrow that is there, which is kind of trying to compensate for this increasing hemolysis or breakdown of the RBCs. Also, extramedullary hematopoiesis is it causes this characteristic facial features. Diagnosis is again by HPLC. And two important questions, just for the question purpose, HBH is when there is deletion of 3 alpha chains, and hydrops fetalis is when the deletion of 4 alpha chains, which is the most severe form of thalassemia. Now we come to the immune hemolytic, that is, RBCs are being destroyed by immune system. So immune system can be the antibodies or the complement. We find these antibodies or complement on the RBC surfaces. Now, because they're attached to the RBC surfaces, our Coombs test, direct Coombs test will be positive. So a Coombs test, a direct comes positive when the antibodies or complement are attached to the surface of the cell, and an indirect comes positive when we check the serum of the patient for the presence of antibodies. Okay, now immune hemolytic anemia, not all are autoimmune. Excuse me. Some can also be alloimmune, like I discussed in blood transfusion. Now, destruction of RBCs is by type 2 hypersensitivity, another very important question. We've covered hypersensitivity in our lectures of immune system. Now, the antibodies can be warm, that is antibodies which are maximally active at room temperature or 37 degrees. Or antibodies can be cold, which are active at 4 degrees. Then again, the cold agglutinin can be because of either infections like mycoplasma or HIV or mononucleosis, or it can be a paroxysmal or suddenly happening thing, which is called as a cold paroxysmal hemoglobinuria. It also often follows a mycoplasma infection. Coming to another entity, which is called as paroxysmal nocturnal hemoglobinuria. Nocturnal means night, paroxysmal means sudden attack, and hemoglobinuria, as the word suggests, there'll be hemoglobin being excreted in the urine. So this is an acquired defect. Like all the previous hemolytic anemias, be it thalassemia, be it sickle cell, this is not inherited. This is an acquired defect, and this is a rare acquired stem cell disorder in which the RBCs are abnormally sensitive to complement. Okay, so now there are mutations. Again, I'm repeating, acquired mutation in phosphatidyl inositol glycan A, which is a portion of the RBC membrane. So there are mutations in this particular element in the RBC membrane, and because this particular protein in the RBC membrane becomes excessively sensitive to destruction. Okay. I'm sorry, here I've written hemolytic action of stem cells. It's basically hemolytic action of complement. I'm sorry for that, typing error. Over here, suddenly the patient will get an attack of hemolysis in the night and will pass dark colored urine in the morning. Also, a very important question that is asked with PNH is that now not only the RBCs are excessively sensitive to complement, also the WBCs and platelets are affected. So this complement can also affect platelets and cause venous thrombosis. There'll be excessive aggregation of the platelets in the blood vessels, in the veins, and there'll be thrombosis. And it can lead to Budd-Chiari syndrome if there is hepatic venous thrombosis, which is rapidly fatal. It can lead to death in the patient. Now, hemolysis can also be due to RBC trauma, as we talked. It can be due to microangiopathies like TTP, thrombotic thrombocytopenic purpura, or hemolytic uremic syndrome, which occurs after an E. coli infection in kids, or due to any mechanical breaking like heart valves, passing through that mechanical heart valves. Now, these broken cells are seen like this on the smear. So these are called helmet-shaped cells or schistocytes. What is schisto? Schisto means broken. So broken cells. Now, at the end, let's just quickly cover what kind of cells are seen in what kind of disease. So oval macrocytes, teardrops, we seen in macrocytic anemia, then hyperchromia in iron deficiency anemia, microcytosis again, chronic disorder or thalassemia trait, sickle cell in sickle cell disease, spherocytes in spherocytosis, elliptocytes in elliptocytosis, autoagglutination is seen in autoimmune hemolytic anemia, fragmentation in any kind of trauma like microangiopathic hemolysis. So this is a flow chart basically to kind of come to a diagnosis as to what kind of anemia it is. So if there's anemia, we do a full blood count and a differential count, and then we come to retic count. Now, as I said, retics are immature RBCs, which are basically trying to compensate for the loss of RBCs. So if there is a decreased retic count, that means that the body is unable to compensate. Right. So decreased retic count can, why will the body be unable to compensate? Either it can be a bone marrow failure or there's some kind of nutritional deficiency. Okay, now if there's a bone marrow failure, we do a bone marrow aspiration or biopsy. If there's a nutritional deficiency, we can do a serum iron, or we can do, vitamin B12 and folate levels. Iron deficiency, again, if iron levels come normal, then we do a hemoglobin electrophoresis to see that besides iron deficiency, what is the problem with the RBCs. And if there is an iron deficiency, obviously we'll go to the treatment of iron deficiency. Then after that, if the retic count is increased, that means the body is able to compensate. So that means there is no problem per se in the formation of RBCs. So it can either be due to destruction, that is hemolysis, or hypersplenism, or there can be a bleeding, right? And also we do a blood smear microscopy to kind of see what kind of cells are seen on the smear to determine the kind of RBC seen and help us with the diagnosis. Okay, so let's come to the questions. Now over here, I have 5 questions, and please, you can put your answers in the chat. And the 5th question is the question of the day, and whoever answers this question of the day the quickest and gives the right answer, we have a surprise for that person. So the Nextillo team will get in touch with you regarding that. Okay. So this is the first question. A positive Coombs test is seen in which hemolytic anemia? You can put your answers on the chat. There is a lag that's going on, so please just, please be patient. Okay, so I can't see the answers yet, but the answer here is positive Coombs test will be seen in SLE, because SLE is an autoimmune condition which leads to hemolysis. And so over here, the antibodies and the complement will be found on the surface of the RBCs and hence will give a positive direct Coombs test. Then the next question is low iron and low TIBC is seen in, that is low iron and low total iron binding capacity of our body. Okay, so what will be the answer? So the options are anemia of chronic disease, a sideroblastic anemia, iron deficiency anemia, and aplastic anemia. Okay, I can see the answers from the previous question now. So yes, Mr. Yadav Sanjay, you are right. The answer is SLE. So these are the options for this question: low iron and low TIBC. So I hope you've put in your answers by now. The answer for this one is A, anemia of chronic disease, because in sideroblastic anemia, there is normal amount of iron, just that it is not being used properly, whereas in iron deficiency anemia, obviously there'll be low iron, but the TIBC, that is the total iron binding capacity, will be higher because the saturation of transferrin is low. That means the sites present for binding to this is more sites are available to bind iron. So TIBC is high in an iron deficiency anemia. Okay. And the fourth is an aplastic anemia, in which there is absolutely normal iron and TIBC seen. So I can see the answers, and well, none of you have given the correct answer till now. All of you are writing C. Yes, there is low iron in iron deficiency anemia, but the total iron binding capacity is high. So because iron already is low in our body, the receptors are free to bind more iron. Okay, so the binding capacity of the molecule which helps transport iron is more now. It'll try to bind more iron. Okay, so the receptors are free right now, so the total iron binding capacity is high in iron deficiency anemia. Okay, so let's go to the next question. Now, which is the storage form of iron? The options are transferrin, hepcidin, ferroportin, or ferritin. So the answer over here is ferritin. Transferrin is basically the transport form. Hepcidin is the enzyme, and ferroportin is our the transport molecule on the surface of the cell. So the answer is D, right? It is ferritin. Great. So all of you are giving correct answers, and the first correct answer is given by Yaduvendra Singh. So that's great. Number 4 is, which viral infection is the cause of transient aplastic crisis? Okay, so we've talked about aplastic crisis. It is caused by viral infection. So which is the most common cause of aplastic crisis in patients? So is it a cytomegalovirus A, or B, Epstein-Barr virus, or C, parvovirus B19, or D, a human papillomavirus? I'm just waiting for your answers. So over here, the answer is C. We have discussed it. Parvovirus B19 selectively infects erythroblasts. That is the immature RBCs, or the blast form of RBCs that are in the bone marrow. So when a parvovirus infection happens, it basically affects all the blast cells for a very short period of time. So there is a transient, that is short-lived aplastic crisis. So in a normal human, when parvovirus infection happens, generally we do not find anemia because our normal blood cells, or normally happening RBCs, are able to compensate for it. But in a person with a disease like a sickle cell or a spherocytosis, the normal RBCs are very low or not there at all. So they're not able to compensate for this aplasia that happens. So the answer over here is C, parvovirus B19. And the first quickest answer was given by Bashu Kant. So that's great. A and B are not the right answers over here. I know that we talk a lot about CMV and EBV causing various kinds of hemolysis, but they are not the cause of aplastic crisis. Okay. All right. So now we are coming to the question of the day, and whoever answers this will be our winner for the day. Okay. So let's go. This is our question of the day. So which is the central regulator of iron metabolism? We've talked about it. We talked about iron metabolism. These are your options. The options are A, ferroportin, B, hepcidin, C, hephaestin, or D, transferrin. So I'm waiting for your answers. Someone said D. Okay. Anybody else wants to answer? Okay, so the answer over here is B, and yes, Sanjana has given the right answer. So Sanjana is our winner for the day. The answer is hepcidin. Definitely, hepcidin is the central regulator of iron metabolism. As I explained in one of the previous slides, hepcidin is a protein secreted by the liver. It is also an acute phase reactant, and it blocks or unblocks ferroportin, which is present on the basolateral surface of our intestinal cell, and hence decides whether the iron from that enterocyte will come inside the bloodstream or will be stored there. So hepcidin, basically, the formation of hepcidin by the liver goes up or goes down depending on how much iron is needed by the body. Okay, so that was it for today. The answer is hepcidin, and it's very important. So you should just remember this for your exam purpose as well. So here we are, and that's it for the day. And I'll see you again in our next pathology lecture. Have a very good evening.